Bismillahirrahmanirrahim. Question number 49. A 31-year-old man is treated with triple therapy, a proton pump inhibitor, and two antibiotics for an endoscopically proven duodenal ulcer. He has tested positive for Helicobacter pylori. After 10 days of treatment, he has improved but is not yet fully symptom free. Which one of the following is the most appropriate follow-up for this patient? 31-year-old man with triple regime therapy and endoscopically proven duodenal ulcer. He was positive for H. pylori. After 10 days of treatment, he improved but is not yet fully symptom free. So, now which of the following is most appropriate follow up for this patient? Serum gastrin estimation, urea breath tests at 6 weeks, repeat endoscopic at 4 weeks, serology for H. pylori antibodies at 2 months, repeat endoscopy at 2 months. So these are the options. Over two-thirds of peptic ulcers are associated with H. pylori. Most of the others are secondary to non-steroidal anti-inflammatory agents, and a minute proportion are a complication of gastrin secretory neoplasm. So two-thirds of the uh, secondary to so the two-thirds are associated with the H. pylori, and others are secondary to NSAIDs, and remaining some are gastrin secretory neoplasm. For a young, fit, and otherwise healthy individual, it would be quite acceptable to provide empirical therapy on the basis of a clear-cut and uncomplicated history. Investigation, preferably endoscopy, should be considered for cases of a diagnostic doubt or where alarm symptoms are present. Which are the alarm symptoms? Including dyspepsia as a new symptom are in a patient over the age of 40, unexplained weight loss, associated anemia, dysphagia, or hematemesis. A gastric ulcer needs to have a stomach malignancy excluded. At the time of endoscopic diagnosis of a peptic ulcer, a sample of a mucosa should be taken for a rapid urease test, which, if positive, will provide indirect evidence of the presence of H. pylori as illustrated. At the same time, further tissue samples should be taken for histological analysis, which might show the presence of the spirochete-like organisms. So here, so urea stays for H. pylori. Above is negative and below is positive. Here we can see one yellow color which is negative, and here is red which is positive. This is urea breath test, and this is also duodenal ulcer on endoscopy. We can see with the here this is the ulcer of the duodenum. Current therapies for the duodenal ulcer of acid suppression and eradication of H. pylori have high rates of success, with more than 90% of patients being cured of their disease within 2 weeks. The relapse rate is low, and in many instances, provided the patient remains fully symptom-free after treatment, no further investigation is required. Otherwise, the most appropriate investigation would be one to look for the presence or absence of H. pylori, and this is done most conveniently with a urea breath test at 6 weeks. Means after starting the treatment at 6 weeks, we can check the urea breath test. The patient ingests a urea compound that has been labeled with C13, and if there is still H. pylori, the upper digestive tract. If there is still H. pylori in the upper digestive tract, this compound will be degraded, and some of the labeled carbon will appear in the breath where it can be mirrored. Serum Gaston assessment would only be indicated for intractable symptoms and would be difficult to interpret as proton pump inhibitor therapy increases levels. Repeat endoscopy to check for ulcer healing is often practiced, but this is unnecessary for duodenal ulcer as the ulcer will almost certainly have healed if the patient no longer has any symptoms. Undertaking H. pylori antibody assessment will only provide evidence of previous exposure to the organism, will not give the information on whether this patient is still infected or not. So urea breath test at 6 weeks we will check for the confirmation of this H. pylori.